Let's go.
Hello, everyone. We will wait for a couple more minutes for more people to join and then we'll start.
Okay, so I think that we're ready to start.
Hello, everyone.
Hello.
Hello.
I'm just waiting for our colleagues from ICMS if they want to say something before we begin. It's fine. Let's just introduce ourselves and then we can begin with the presentation. My name is Yordan Kovatchev. I'm a radiology resident at the Kula Hospital in Sofia. This is my colleague.
Hello, and my name is Tsvetomir Karagechev, and I'm also a radiology resident working in the radiology department in the GBDM City Clinic, University Hospital Tukula. Now I think we're ready to start.
We'll present you the emergency head CT workshop and try to make it as interactive as possible for you. So at any point, you can write in the chat or even join the conversation if you want to ask something. Just write down your questions as well. We'll look at them the first opportunity. And now let's just begin. I'll give the word to my colleague.
Okay, I just want to know if everyone sees my screen.
Yes.
Yeah, it should be fine.
Okay, can you hear me?
Yep.
Okay, so good morning, everyone. Warm welcome to you all on this cloudy Saturday morning. And me and my colleague, we are both really glad that you decided to spend the next hour or hour and a half with us. As I said, my name is Dr. Tsvetomir Karagechev, and me and my colleague, Dr. Yordan Kovatchev, we prepared this online workshop dedicated to head CT imaging in the acute setting. And both of us will present different sessions during today's talk. This workshop is part of this year's ICMS promo days, and we want to, before we begin, we want to acknowledge the effort of the organizing committee and show our appreciation for their invitation. So a brief introduction. So why we chose this topic? I think that many of you are aware that a great deal of all emergency CT studies that are reported by general radiologists or junior radiologists or people who are in residency are head CTs. Most of the times we are challenged by real life-threatening conditions, and misinterpretation of the findings that tend to be really subtle sometimes can lead to a bad patient outcome. So, our objectives for today's talk: we will review the cross-sectional anatomy of the brain so you can find your way around the scans. We will introduce some basic technical principles that are essential for understanding the CT modality. We will show you a basic and systematic approach, so how to look at head CTs. We will talk about how to assess symmetry and asymmetry. We will review the terms hyperdensity and hypodensity. And of course, the main characters of today's session will be the cases. And through the cases that we chose, these are cases that we've seen during our practice. And through these cases, we will present to you real life-threatening pathologies like ischemic stroke, interparenchymal hemorrhage, suprarachnoid hemorrhage, hydrocephalus, and others. So I'm sure that many of you recognize one of the most famous photos in history, but still confused. So what is the connection between the Beatles and today's talk? And it was actually the meteoric success of these four people during the last century that changed radiology and medicine forever. In 1962, the Beatles signed with EMI, Electric and Musical Industries, and because of the meteoric success and the money they earned from record sales, the very same company, Electric and Musical Industries, funded the research of this man, Godrich Hounsfield, and in 1971, the first CT scanner was produced. And this is actually the first image of a living patient. It took the reconstructions of the images took a whole night, but in the end, a recognizable image of a brain tumor was produced, and even Hounsfield himself was amazed from the result. After that, the life of every radiologist, every physician, and every patient all around the world was never the same again. So this is how a modern CT scanner looks like today. And if you're following basically any Facebook or Instagram page with medical memes, I think you're familiar with this concept of the CT scan. So before we start, I promise to you all that we won't dive deep into physics during this talk. I will present the basic technical principles as simple as I can. So what is important? The CT scan is an X-ray machine. It uses X-rays. Unlike MRI, there is an actual radiation effect to the patient. And there is a source, X-ray source. It produces an X-ray beam, goes through the patient. It reaches the detector as they spin around the patient. And then some fancy physics and some fancy computer programming happen. And the end result is that we get a cross-sectional image. So another important principle is that when the X-rays go through the patient, they get attenuated, and they get attenuated differently depending on what kind of structures they go through. The end result is a visual representation of this process, a shade of gray that corresponds to a number. You can see them on this side of the screen, on your left side of the screen. These are the Hounsfield units or the CT numbers. So as you can see, these are some basic and important tissues that we looked at when we interpreted head CTs. And on the very first side of the spectrum is air, which has a value of -1000 or -1000. Then we have fat, like -50 to -1000. And then you can see in the middle of the spectrum is cerebrospinal fluid around 0. It's actually around 0. It's like -10 to +10. But what's important is that it's in the middle of the spectrum. So between -1000 and +1000. So this, as a shade of gray, will look like intermediate shade of gray. Now, some important messages: white matter and gray matter, so the brain tissue, they have actually very similar attenuation, and gray matter is actually brighter on a CT scan than white matter. The next one, and this is the first take-home message for today: blood, acute blood, has a range of CT numbers like between 40 and 90. Of course, this depends on the hematocrit level, the hydration of the patient, and the aging of a hematoma. But what I want you to remember is that acute blood has higher attenuation than brain tissue. The next thing, focal calcifications, I wrote it like that just to remind you and to make you remember in the very beginning that calcifications, we see calcifications all the time, but benign calcification, physiological calcifications on the brain CT, it has a value of over 100, so they're denser than acute blood. As I said, we see them all the time. You don't want to confuse physiological calcification with a hematoma. And on the other side of the spectrum, bone, positive 1000. So as you can see, in the whole spectrum of CT numbers and shades of gray that we looked at, they're like around 2000. So in our books, there are definitely a lot more shades of gray than in other. So this is a better visual representation of this concept. As you can see, this side of the spectrum, air, -1, -1000, pitch black. On the other side, cortical bone, pure white. Intermediate density, benign fluid like cerebrospinal fluid or urine. And then here is the brain tissue. So intermediate shades of gray. So when we talk about head CTs, there are actually 3 different exams, and they all have different indications. I won't go deep in this topic. We will show you examples when we start presenting the cases. The exam that we perform most commonly is head CT without contrast or non-enhanced CT. And then on the second picture, you see a head CT with application of intravenous contrast, and we do that when we want to look for blood-brain barrier breakdowns like in neoplastic or infectious lesions. And the last picture on your left is a CTA or a CT angiogram, and this is actually vascular imaging. It is also a contrast-enhanced imaging, but in this case, we rapidly track bolus of intravenous contrast media in order to assess the vessels. So the difference between CT head with contrast and CT angiogram is basically the timing. So the next, and I really promise the last technical concept that we're going to review today is windowing. And this is basically the way we present our images, the way we present all of these shades of gray. And as you can remember from a few slides ago, there are around 2000 shades of gray in CT, and the human eye can only detect a fine number of CT images, of CT numbers that represent the shades of gray. And if you put them all down on one image, we won't be able to differentiate between clinically important densities, and that is what windowing is all about. So what I want to show you, let's zoom in this a bit. When you open a brain CT, there is a default window, and every window has 2 components. There is the window width and the window level. And the window width is actually the range of CT numbers displayed on the image, and level, or the center, we actually choose this number depending on what structures we want to look at. And we choose it to be similar as the CT numbers of the structures that we are interested in. And I will show you some examples to better understand what I mean, because as you later see, this is really important. So we have the default brain window, the width, and the range of CT numbers between 0 and 70. White and gray matter are really here in the middle. So as you remember, they're around 30 to 40, and that's why we chose this level. What is the problem here? Acutely clotted blood has a CT value, a Hounsfield unit value of like 80. So everything above 65 on this window will be completely white. This is true for clotted blood, but also for bone. If you have a layer of blood laying just over a bone, you won't be able to differentiate it because they will be both completely white. This is why we have the subdural window, or the blood window as you can find it, and it is actually a wider window. You can see here the width is 180 and the center is 80. So this is where we expect clotted blood to be. So in this case, acutely clotted blood with the CT number of 80 will look grayish. Bone will still be completely white. In this case, you can appreciate and spot really subtle hematomas laying over the bone. So what we have next, and of course, as I said, this will be a lot clearer when you start talking about stroke and hypodensities during one of the next sessions. But for now, just remember that there is such thing as a stroke window. It's really narrow window. You see the width is 30. The normal of a normal brain window is 70. And we do this so we can appreciate subtle differences in white matter differentiation. And here you can see the three examples. You have the brain window on the first picture, the normal, the default setting. The second picture is the stroke window. You see that the differentiation between white and gray matter is really accentuated on this image. And on the third image, the subdural, the broad window, you can be so sure about gray-white matter differentiation, but you can spot subtle hematomas. So before we start with the clinical questions, you can't really appreciate abnormal if you don't understand normal. So in the next session, Dr. Kovatchev will take you through the section on the CT anatomy of the brain.
Okay, thank you for the introduction. The Beatles part was really nice, actually, and I didn't know about this. And we were talking at our department a few days ago about such historical facts. And one of my colleagues said that during the 18th century, the pineal gland in the brain was called the brain penis. So, there's one interesting fact for me. Can you actually share your presentation on the screen? And I only have a few slides there about anatomy, and then we'll just go to the more interactive part.
Okay, just tell me if you're able to see it.
Yeah, just.
Okay, I'll just need to scroll really quick to the part where we were. Sorry about that.
Okay. Sorry. Okay, let's move on to the next, I think, one slide.
Yeah, okay, wait a second.
So, yeah, onto the left, with the stethoscope is where it begins. I will talk about the hypodense part of the brain, but before, like you said, I will just go over anatomy. And I don't mean it, for me, anatomy in university was really boring because I never made sense of it. It was just memorizing some stuff in the body, but when you connect it with what you're actually seeing every day with the patient, it's really interesting. I see it a whole different way now when I'm practicing medicine. So I'll show you the most important parts of the brain that are related to what we're talking about. We can't learn the whole brain anatomy in one day or even a week, but I just want you to remember when you think about anatomy that even if you don't know something while you're reviewing a CT scan or you're talking about a colleague, just try to connect it, to make a logical connection and to figure it out, to research. I'll show you some tools that I use every day because we see probably 100 brain CTs every week, and still I open a textbook, an article every day to check something. So don't think that you have to know everything. Just try to understand the underlying connection. Can you change to the next slide? Before I show you the vessels and the different lobes of the brain, which is an important part to our talk, these are there are two take-home messages from my part of the presentation. Even if you don't listen to anything else I say and you don't remember anything else, just try to remember these two things, because they, as we said in the beginning, when we look at CT, these are the things that we try to notice first if they're present or not. And this is if there is edema in the brain. There are two types of cerebral edema, cytotoxic and vasogenic. This is the first type, cytotoxic, where you can see, like we were talking until now about the gray-white matter differentiation. You can see here how it's lost on the left side. Sorry, this is the right side of the brain. When we look at the brain CT, it's inverted. So on the right side of the brain, on the left side of your screen, when you look at the CT, you can see how there is a big hypodense. So this means grayer area where the gray and white matter differentiation of the brain is lost. This is the first type of cerebral edema, and this is due to swelling due to cellular swelling, because we get this usually in infarction. This is what we'll talk about. The other cases are more rare, maybe for another workshop, but think cytotoxic edema, infarction, because when the cell infarcts, the sodium-potassium pump gets disrupted, and then you get cellular swelling. This is on microscopic level, but what we see on the CT is this big area, or it might be a small area, as I'll show you, where basically we don't see the difference between gray and white matter. They're smudged. It's all just one thing, as you can see here on the left side, which is the right side of the brain. So cytotoxic edema, loss of gray-white matter differentiation. This is usually due to ischemia or brain infarction. And on the next slide, I will show you the other type that I want you to remember, which is vasogenic edema. The main difference, and you can almost always, but not always, differentiate it on CT, is the fact that you can see the gray-white matter differentiation. It's intact. Actually, it's accentuated because the white matter, which is here grayer, so I know it's a bit confusing the first time you look at CTs, but that's how it is. The white matter, which is the subcortical matter, right? Because the gray matter is the cortex, is more hypodense, so more gray, and you can see better the differentiation between the gray and white matter. And in this case, the blood-brain barrier is destroyed. So we get extracellular fluid. This is what happens on microscopic level. On the CT, we get accentuated gray-white matter differentiation. And this type of edema, vasogenic edema, is usually due to a tumor or metastasis. In adult brain, when we see that, this is usually the case. Sometimes it can be due to abscess. It's more rare, but it's an absolute emergency. And you differentiate between the two when the patient has some signs of septic shock, because if there is a brain abscess, then this is really important immediately to do an MRI, immediately to contact neurosurgery and so on. But I'll show you more common cases that we see every day, which are related to tumor metastasis. And specifically, when we look at an adult brain, the primary tumor would usually be a glioblastoma, and metastasis would be from several different primary tumors, such as breast cancer, renal cancer, and so on. But just remember right now, vasogenic edema, there is gray-white matter differentiation. It's accentuated. You can see it really well. And it's usually due to a neoplastic process, underlying neoplastic process, or an abscess. And can you switch the slide, please? On the next one, there are two more slides that I want to show you, which are related to anatomy itself. So you know now what edema is, swelling of the brain, the two types of edema, and I'll show you a bit more how you can differentiate them on actual CT. But the reason that edema is so important to us is because it has mass effect. The edema itself initially is not a problem, but if it grows exponentially, it starts compressing structures next to it, and this can lead to one of the other things that we always look on initially on CT, which is whether or not there is hydrocephalus. To understand hydrocephalus, you first have to remind yourself of the anatomy of the ventricular system of the brain. Now, there are many parts, as you can see, but I want you to remember the major ones, because this is what I will show you. And exactly the lateral ventricles, especially, they're on both sides. You can see the arterial horn on the front, the body, then there is an occipital horn, and really, really important is the temporal horn of the lateral ventricle. On both sides in the temporal lobes, we have temporal horns, and when there is hydrocephalus, which means that when the brain is swelling and there is fluid, there's more fluid in the ventricular system, this is the first part in the brain where you see it in the temporal horns, and we can really early differentiate whether a patient will develop hydrocephalus. And then they're all connected, as you know, because they drain into the spine. The other ventricle that I would like you to remember at this point is the fourth ventricle at the bottom, because it's located in the posterior fossa. And when we see its so-called effacement or compression of the fourth ventricle, we can this is an early sign that something is going on in the posterior fossa of the brain. So you look at it, if it's fast, we expect hydrocephalus will develop, and we have to concentrate on the posterior fossa to see if there is something causing mass effect there. And on the next slide, I will show you the overall arterial anatomy of the brain. Again, there are many arteries. I don't expect you to know them now or remember them from this talk. I just want you to be aware of them and research them after you understand their connection, their importance to the emergency head CT. But basically right now, when we start from the bottom up, we see the posterior circulation of the brain. As you know, there are two main parts of the circulation of the brain, and the posterior circulation is provided from the vertebral arteries on both sides of the spine that collide into the basilar artery. And the basilar artery goes up into the brain, and the top of the basilar artery is called the basilar tip. It's really important because sometimes we see thrombosis there, and then it divides. The branches that come out go or below that go to the brainstem, the posterior part of the brain, and also really importantly, they give the posterior communicating artery that goes to the front, because as you know, this is the circle of Willis. Everything is connected. It's really important because it provides collateral blood supply. In case of infarction, that's what saves a person's life initially. And on the front, we see the carotid arteries that go through the neck up to the carotid siphon. They have 7 segments. Anyway, when the carotid arteries enter the brain on both parts, they become the middle cerebral artery, and they supply, I would say, really the majority of the brain. So this is the one artery that I want you to remember right now, even if you forget the others. The middle cerebral artery, it's a continuation. On both sides there is one. It's a continuation of the internal carotid artery, and we call it, just for short, MCA, because I'll show you now. I'll say this is something in MCA here. It means the middle cerebral artery, and it provides arterial supply to a major part of the brain. So you can look at it afterwards to remind yourself of vascular anatomy, but this is the basics. Can you switch the slide so I see if there's anything else I need to talk to before I go to the cases?
Okay, let me check.
Yeah, this is the stroke protocol. I'm going straight now to show you how to interpret head CT, and you'll do it with me. Don't worry, I'm not going to quiz you. Just if you're interested, I'll try to make it as interactive as possible to you. I'm sending you a link in the chat now, because this is a workshop after all. You can open it if you want, participate. If you don't, it's fine. You can look at my screen. I'll share my screen now. But look at the last link I sent in the chat here. Just open it, and you will see, you can go along with me as I try to explain to you how I look at every CT. Again, in the beginning, I'll do a bit more of anatomy, and not just like in a slide here, but actually how we see it on an actual CT. So whoever wants to do it, I would recommend open this link, or and also follow my screen. I'll share now, because you can really get the feel of what it's like to go through a head CT. When I was a student, I never got this opportunity. We had to go to the last year and even graduate, and then I still hadn't had the chance to look at the head CT. And actually, you can all do this. You can do this online nowadays, and you can really learn a lot. So I'm sharing my screen now. Can you just confirm that you see it?
Yes, we can.
Okay, great. So I sent you the link to this playlist. You can look at it now, you can look at it later, it will be saved. You can just scroll to the CTs to get a feel of what it's like to look at a head CT. We do this every day, really tens of times. Before we actually look at some patients, I will put into practice what I was telling you about now, the anatomy, and just go into a little bit more detail, because I don't expect you to know all this. I actually don't. I look at this and another graphic a few times a week just to remind myself of some details that I might forget. I really want to focus on that. It's really important. You have to know where to look for information. You don't have to know everything. It's impossible and just counterproductive. Try to think logically and try to look for the best source of information. But let's look at the basic anatomy now again, but this time on cross-sectional imaging, so you can make sense of it in your head. We'll start from the bottom up. We go to spinal cord, enters to the foramen magnum here, right, and it turns to the brainstem. What I want you to notice here are the two vertebral arteries, as I showed you earlier. They will collide on the top into the basilar artery. So here they go, the vertebral arteries, and this already is the basilar artery. And it goes up, the basilar artery, and then here is the circle of Willis. It's not so easy on cross-sectional anatomy as in the textbook, but basically the basilar artery connects with the posterior communicating arteries to the frontal circulation. And here on the frontal circulation, we see the carotid arteries on these red dots. They enter the brain. They provide, and they turn into the middle cerebral arteries. They have 3 segments. That's not really that important right now. Just remember, this is the middle cerebral artery. On both sides is the continuation of the internal carotid artery in the frontal circulation. Now, some gross anatomy. The lobes, here we have the infratentorial space. So this is below the tentorium, where the cerebral hemispheres are. This is the left one. Remember, on your screen on the right, we see the left part of the brain, and this is the right cerebral hemisphere. And this is what I mentioned to you, the fourth ventricle. It's pretty small. I'll show it to you now without annotation, but we always look at it because if we see that it's smaller than normal, then we think there is mass effect in the posterior fossa. And that's really important because it means that there is something going on there, and the patient will develop hydrocephalus. This is the pons, part of the brainstem. We go up, and now we're over the tentorium. Here is the tentorium. It's a bit hard to see here, but when we get over the tentorium, we're in the supratentorial space, where this is the majority of the brain, obviously, and we will look at the main lobes. Here is the occipit. On the back are the occipital lobes, the left one, the temporal lobes, left one, and right on the other side, and as I mentioned, the temporal horns of the lateral ventricles. Again, really important. If we have hydrocephalus, this is the first place where we will see them. The first place, almost always. We go up. The rest there of the basilar systems, different parts of the ventricles. But what I really want you to focus on now is the basal ganglia. And this is what almost all the cases that are connected, almost all the cases that I will show you now are connected to the basal ganglia. As you know, in this area, there is white and gray matter. The internal capsule is made out of white matter, and the basal ganglia are subcortical gray matter, because, you know, the gray matter is usually on the cortex, but they're also inside the brain. There are areas where we have gray matter, and the ones that are really important to us are the basal ganglia. Here is globus pallidus, is the putamen, and the head of the caudate nucleus. But even if you don't remember exactly right now which one is which, just try to remember that here are the basal ganglia, and they're really important because they will be affected first when we have ischemic stroke, and the thalamus on the left side, on both sides, the left one and the right one. It's also important, as they say here, to understand this anatomy, because often the clinical presentation, when you see the clinical presentation, that's why it's really important to us to know what's going on with the patient. We can correlate it to different parts of the brain. So you need to understand where everything is and how it's connected. I'll show you now with the cases. It's really interesting, actually, most of the times. And then we finish with the bodies of the lateral ventricles. Here they're normal. They will be enlarged if there's hydrocephalus. Now, as we go up, this is another thing. My colleague, Dr. Karagechev, mentioned this, and I want to say it again. It's so important. The gray-white matter differentiation. And as I said, with the different types of edema, do you see the gray-white matter almost clearly? It's hard, I know, but almost clearly with different density between each other. As you can see here, the gray matter is the cortex, and the white matter is subcortical space. Here is actually, the frontal lobe and the parietal lobe on the back. So this is the frontoparietal region, but that's not really important. It's important here to see if we can differentiate between gray and white matter, and I'll show you now without the annotations. Here again, showing the lobe, frontal lobe, parietal lobe. This is the central sulcus. I'll show you a case with that, and the two maybe the most important gyruses that you need to remember, because they have direct correlation to the clinical presentation, the precentral and postcentral. And then we go up to the top, and you can see the falx here. The falx is really important because the falx here, it's actually what I was showing was the superior sagittal sinus, but the falx is below it. It's really important because we follow it through the middle and through the middle between the two ventricles to decide whether there is midline shift. If there is mass effect, we'll see at the level of the ventricles how the midline is shifted to one side. We call this midline shift, or if you want to sound more fancy, it's called subfalcine herniation, because the brain is herniating to one side below the falx. Okay, anyway, let's show you now without annotations. We go down and we'll start from the bottom up again. You see the basilar arteries well demarcated by cerebrospinal fluid there is around, because it's important here. These are the tonsils of the brain. They should be about 4 or 5 millimeters below the foramen magnum. If there is more, then we call this tonsillar herniation. It's really, really important, because we need to do, then the neurosurgeons need to do craniectomy, or we need to put drainage. There will be hydrocephalus and so on. This is the posterior fossa here, the two cerebral hemispheres, the brainstem. We go above the tentorium. Now we are in the supratentorial space. We have the parietal lobes, occipital lobes, sorry, frontal lobes here. And again, I'm going to the basal ganglia. This is really, really just remember this image, even if you don't actually remember which is which. This image has to be etched in your brain, because when you open a head CT, 90% of the cases in emergency setting, you're doing a night shift, this is where the pathology will be. You see something here. It's really, really often. Again, the caudate nucleus, thalamus, lentiform nucleus, and here is a really important strip of gray matter. It's called the insular ribbon. It's gray matter, and below it is the external capsule, which is white matter. So we should be able to see a differentiation here, gray-white matter differentiation. Okay, enough with the anatomy. Let's go to the cases. And as I said, you can you can follow along with me. Just watch the screen, or actually scroll yourself. By the way, I'd be happy if you unmute your microphone, say something. It's fine, don't worry about it. After, let's do one case, and we'll do 2 or 3 minute break also, so that we'll continue afterwards. What I forgot to mention, and it's really important that I added it here in the playlist, because after all the anatomy talk, why do we really need to know all these anatomy? Why do we need to know where the vessels are? Which are the lobes? This is really why. And this is why you study anatomy. It's not just to be able to pinpoint some part of the brain and say, this is the clivus or whatever. This doesn't matter. You need to understand why you know this anatomy. So this is something, in Radiopedia, I open this at least a few times a week at the cerebrovascular territories to check, because when I see a change somewhere in the brain, I have to think, it's there. So which artery supplies this part of the brain? So I need to start thinking about the underlying pathology. So let's start from the bottom again. I'll skip really the small details here because this is for a whole other workshop that takes hours to understand the really small vascular territories of the brain. So I'll just go straight to the ones that will be important to our talk. As I said, remember the middle cerebral artery, it supplies a really big part of the brain. And this is everything here is supplied by the middle cerebral artery, everything here in the brain. As you can see, they've noted a small part, the lateral lenticular arteries, because they supply the basal ganglia, and they're the first signs when someone has ischemic stroke. The first changes will be here in the basal ganglia, because these arteries are terminal arteries. There are no collaterals, so these areas are really susceptible to ischemic shock. The first changes we'll see in a patient with stroke will be in this part, and then of course we'll go to the rest of the MCA. I'm talking about the MCA because really most of the cases are with thrombosis of the middle cerebral artery. Of course, any artery in the brain can thrombose. We see often this is the ACA, the anterior cerebral artery. We see ischemic stroke here, the PCA. But what's really important is to understand that when you see some change here, it won't cross this margin between the vascular territories. And that's how initially we think that maybe there is infarction there. Because if there's something that's affecting all the area here, either that's a watershed infarct, it's more rare, it's usually attributed to some pathology of the carotid artery, or more often there is a mass, there's something else going on, but it's not an infarct. When you see changes that's clearly demarcated in these vascular areas, it's clear indication that there's something, that there is a vascular problem going. So you can save this. It's really cool to look at it as a reference, because when you open any head CT and you see a change, you can just relate to this article and think about which vascular territory is affected. So right now, just try to remember the vascular territory of the MCA on both sides. So this is the cortex here. These are the basal ganglia. The basal ganglia, they're all supplied by branches of the MCA. So I think on the next part, I'll go straight to a case. Yes, a 70-year-old male. You can also open this yourselves. It's in the playlist. A 70-year-old male with altered conscious state. And okay, all of this boring stuff that you're listening to me right now. Let's get to business. Actually, you're a radiologist at the night shift. This guy comes to you. They send him to you from emergency room. You have no information. You're tired, and then you open this head CT, and there is a subtle change that you have to notice. This is really what I want you to. This case, all the others are really interesting, but this case is an example of something that you can't miss. You have to notice it, because it's so important. It can make the difference between the patient almost fully recovering from a stroke and the patient being paralyzed for the rest of their life without being able to speak and so on. So when you look at the brain, let's start from the top. You see the gray-white matter differentiation here. It's saved. Here is the cortex. It's white on the CT, or let's say a bit hyperdense, but this is the gray matter. This is the cortex, and below it is the white matter, which is a bit grayer, but it's white matter, so they're inverted. The logic is inverted. And you see the falx, it's in the midline. There is no midline shift. You see the sulcuses on both sides. They're symmetrical. There is cerebrospinal fluid in the subarachnoid space. These gray areas, these are the sulcuses and the gyri between them. And we go down, everything seems normal here. There is no effacement of the gyri, so we don't see any edema here. But we get to the level of the basal ganglia, and I told you this this is really important to our talk. At the level of the basal ganglia, at first you might not notice something, and I'm not looking at the chat, but if someone says it, I'll be really happy, because it means you have some interest in neuroradiology, and this is the first thing you will learn. And the fact that
ribbon sign on the left.
Sorry,
the ribbon sign on the left.
Yeah. Can yes, on the left side. Just 1 second. Right here, this is the left side. You mean the insular ribbon, right?
Yes.
Yes, exactly. Yeah, this is the one of the two things that you have to see on this CT. This is the first thing, or if you start from the bottom, is the second thing. But in our case, the first thing. What he meant by this is, you see on the right side the insular ribbon, or the cortex here. This is gray matter. You can see it pretty well. I know it's not easy on the first time, but you can see the cortex here pretty well on the insular region, and below it is white matter. Is the white matter of the external capsule. You can pretty well differentiate between the two of them, right? Here you see a cortex and white matter. Here, white matter below the cortex. And look on the left side. On the right side of your screen is the left side of the brain. On the left side, it's all, let's call it smudgy. It's all the same in the insular region. You don't see the cortex. And this is called loss of the insular ribbon sign. And it's a sign of acute or even hyperacute infarction. It means that we're in the first few hours of the infarction. And this, as I said, this region is affected because it's applied by terminal branches of the MCA, the middle cerebral artery, and there are no collaterals. So this basically this is cytotoxic edema, right? There is loss of differentiation between gray white matter. This cytotoxic edema. There are no collaterals. The brain is starting to die. There is swelling, cellular swelling, but the cortex here on the frontal parietal lobe region, it looks normal. This is still MCA territory, but the cortex looks normal. And this is because there are collaterals from the ACA, from the anterior circulation, the posterior circulation. There are collaterals that supply this region, so it's still not infarcted. There is ischemia, but it's compensated. Whereas here, there is no collateral circulation, so the brain is already dying. It's really susceptible to ischemia. So good job on noticing this. I wonder if you see the other thing that we need to notice on this exam before I continue with the other one, because I don't want to bore you with just one patient.
Dense MCA sign on the left again.
Great. Good job. I'll show you again what it means, but just first to say what's normal. We don't see effacement. Here's the fourth ventricle. We don't see effacement. It's normal. The fourth ventricle is normal. There is no mass effect in the posterior fossa. Basically, the infratentorial space looks normal. It's not really easy to diagnose infratentorial cerebral brainstem pathology with CT, because there is something we call a beam hardening effect. You see these lines here because there is a lot of bone here, and this effect makes from the bone. This makes the diagnosis of the infratentorial space pretty hard. But still, if there is an infarction of the brainstem, let's say, it will always respect the midline. As I told you, the midline is really important. If you see a hypodense region here, which means grayer region, and it doesn't cross the midline, there is high suspicion of an infarction in the brainstem, and we need to do an MRI, or we need to raise this high suspicion to our clinician colleagues. We need to say there is a high suspicion of brainstem infarction. We don't see that here. We just see these artifacts, these lines here. These are artifacts. The brain is normal, and then we go up, and as our colleague said now, we see what we call hyperdense MCA. So I told you about loss of insular ribbon. Write this down. You sound smart when you say it in front of your friends. And then the second thing I want you to remember is the hyperdense MCA. Remember, I emphasized on the MCA. It's really important. The carotid arteries enter the brain and they turn into the middle cerebral arteries. Let's look at the normal side first. The right side of the patient, on the left side of your screen, the internal carotid artery enters. It turns into the it's not really well seen here because it's a native non-contrast CT. It turns into the middle cerebral artery and it goes up, and that's it. It supplies the region and so on. On the left side, you see the internal carotid artery enters, and then it's hyperdense. It's almost like the bone here. No, not like this, but it's whiter, right? This is what hyperdense means. It's whiter, and you can follow it. How here it's a really good slice. You can see how it's hyperdense along its way. This is called the hyperdense MCA sign, and it means that this is actually a thrombus. We see the thrombus inside the artery. And it's pretty common. We don't see it every day, but it's pretty common. But you have to spot it, because when you spot it, and you do a bunch of other things that there is no time now to explain, but basically the patient can go not only into intravenous thrombolysis, but they can also go in the interventional radiology department, and they can have their thrombus extracted. We can have a mechanical thrombectomy and significantly improve the outcome of the patient. That's why I want to remember this: the loss of the insular ribbon and the hyperdense MCA. When you see this, you do a CT angio. As Dr. Karagechev said earlier, this is another type of CT scan where we inject contrast and we actually look at the arteries. I will show you that a bit later. So let's move on. These are annotations just to see. I didn't mention this, but the on the left side also the basal ganglia, you can see how they have lost a bit their gray-white matter differentiation. Is also a sign, but really this is the loss of the insular ribbon. It's really the most important here, loss of the insular ribbon and the hyperdense MCA. Okay, let's move on to the next case. Just before we go, let's have a 3 or 4 minute break. So right now it's 12:02. At 12:05 we're back. Okay, I'll just mute my microphone. At 12:05 we're back. Just toilet break, and we will be right back and to continue with the rest. So any questions so far? You can write or unmute your mic. Just ask me. Don't worry about it. In the meantime, we have 1 more minute break. I just want to show you something. When I was talking about the loss of the insular ribbon, so many times in radiology, you look at the CT scan and you don't really know what's going on. You just sense, if you can say that, sense that something is wrong because you've seen some CTs, you have some experience, your eyes experience, you think logically, but then sometimes you see that something is wrong. It just strikes you at the CT when you look at it, and this is, for me, is a big part of radiology. You don't always know what's going on. You look at the CT and you think there is a problem there, but you have to always be able to figure it out. So an advice I can give to you when you look at CT scans, especially in emergency setting, is just remain calm. Once you notice, a big part of radiology is noticing some change in patterns. There is something that's off, and then you start thinking about it logically. Which part of the brain it affects? Is it confined to a vascular territory? Do we see some signs of ischemia, or do we see some signs of a tumor that I'll show you later? So there is one article, but I guess it's paid now. It used to be free in the New York Times. It's called AI versus MD. I would recommend to you that you open. It's like pop culture article. It's not really scientific, but when I read this article, I really related to it because it says how sometimes when a radiologist look at the CT scan, only they can say that something is wrong and they can really say what it is. But if you've seen Breaking Bad, the TV series is great. In one of the first episodes, Walter White says, chemistry is the study of change. And for me, radiology is like this. I showed you a normal CT scan, and afterwards I show you a CT scan when there is something wrong. You see a change, and then you figure it out. Don't worry. Just try to notice the patterns at the important levels. When you see something is off, you figure it out. You just have to have a structured approach. Think about anatomy. Think about what this area of the brain, what functionality it has for the patient, and if it correlates to the symptoms. So I'm saying this because in the next case, we have a patient with left-sided body weakness. Now, he has symptoms on the left side. So we will think about maybe there is a change in the right side of the brain, which would be the left side of your screen. Again, I'm repeating this because I know it's unnatural until you get used to it. Let's see, you can see this, right? Yes. Now, we have a patient that has left-sided weakness. We go down. I'll just give you a minute to look at the CT yourself if you're looking at it. And I'm using this case to show you a concept that's a big part of daily practice, as Dr. Karagechev said, windowing. And this is the stroke window. This is the brain window. That's, as he said, the first thing we see when we do the CT scan. And this is the stroke window, because if you look at this CT, I'm not entirely sure that I see a change in the basilar ganglia. I go up, maybe here, yes, in this part. But I'm not entirely sure. Maybe hyperdense MCA, but then I window it. So I change the settings in a way to accentuate the difference between gray and white matter. Because as I said, it's really a key concept that I want you to take out of this workshop, the gray-white matter differentiation. And in the stroke window, we can see it really well normally in a normal head. So this patient had left side weakness, right? So we're expecting some pathology on the right side. And does anyone want to take a guess? Looking at the stroke window, look closely at the gray-white matter differentiation. There is no midline shift. This is another thing we look at as well. There is no midline shift. There is no hydrocephalus. We see the ventricles. Sorry, I'm skipping a bit. We see the ventricles are not dilated. We can barely even see the temporal horns, which is a good sign, because here is where the hydrocephalus will start. We don't see, it's hard to tell really, but no obvious evident pathology in the infratentorial space. The bones look fine. What we see, however, is again, and basically the same case, but it's so important that's why I'm showing it to you again on another patient. On the other side, a patient with left side weakness, and we see the loss of the insular ribbon sign here. It's more subtle, right? It was a bit more evident on the first patient, but on this patient, when we look, it's kind of hard. It's not a great scan as well, but it's kind of hard to see here. And we do the windowing, and then we compare. And even if you're not so experienced, all you have to notice is there is some change. There is some pattern. There is something going on, and then you figure it out, I promise you. Here you see how on the right side, on the left side, sorry, you can follow the insular ribbon pretty well, the cortex, the basal ganglia, the thalamus here, caudate nucleus, lentiform nucleus, internal capsule, it's white matter, so it's gray here, external capsule, white matter again, so gray on the scan. But on the right side, you see a loss of gray-white matter differentiation. This, as I said, this is sign of cytotoxic edema. There is even maybe a little bit effacement of the sulcus, the different sulcuses here in the insular region, and you see the loss of insular ribbon sign. Please remember that. I think it's a bit more advanced in this case because you can see some cortical changes in this part. This is, again, look how strictly demarcated this. This is the posterior PCA zone, and this is the MCA zone. Here, it's kind of smudgy. There is an initial loss. There is some cytotoxic edema. And here, middle cerebral arteries, both sides, you see on the left side how it goes up. It's discrete, but you can notice it. It goes up, it bifurcates. There are M1, M2, M3, there are different segments. And then on the right side, you see the carotid artery turning into the MCA, and it's more hyperdense. So it's more hyperdense than on the left side. It's not so obvious as in the previous patient, but it seems that way. And in this patient, we will definitely do a CT angiogram. Let's see if I got it right. Yes. Hyperdense MCA. So, okay, let's move on. Something different. You remember already the loss of the insular ribbon and the hyperdense MCA. At least these two things with cytotoxic edema. Remember about acute infarction. Acute because we're talking about emergency situations now. So acute infarction. See, so the so-called effacement would be a sign of edema as well. Hyperdense MCA, as I said, vanishing basal ganglia. This is, again, loss of gray-white matter differentiation, but in the basal ganglia specifically, and the loss of the insular ribbon sign. These four. They will remain in this link. Don't worry, you don't have to take notes, but you can come back to that and review them, because I promise you, if you remember this, you'll feel more confident when you look at head CTs in the emergency setting. Now let's move on. We have a patient, 53-year-old male, with acute visual disturbance, right homonymous hemianopia. Now, before we go to the scan, can someone guess where we should be looking at? So the patient has visual disturbance. So which part of the brain? Obviously, we're looking at the whole brain. We concentrate. We look for these changes that I already mentioned. But when you here, when you read that there is visual disturbance,
left occipital zone?
yes, occipital. Yes, occipital is the correct answer, right? Great. So even before you open the scan, that's why clinical information is so important. Even before you open the scan, you can, and honestly, some of my colleagues can confirm that sometimes you just already know what you'll see. I mean, you just open the CT just to confirm it, but you already know what you will see. So let's check the CT scan. Let's go a bit structurally from the top again. Here, basically, we see the sulcus on this side, on the frontal side, symmetrical, not effaced. So you see this dark fluid. This is the cerebrospinal fluid. It goes in the subarachnoid spaces. There is no edema. On the back side, so this is the back side, the occipital lobe, you see that there is something going on. Even if you can't put it into words initially, there is something going on here. This is what you have to notice. Here on the left side, we see subarachnoid spaces that are fine, filled with cerebrospinal fluid, and we see gray-white matter differentiation. This is the cortex, this is the white matter underneath. We see that the midline is, well, there is no midline shift, the fox in the middle. But on the right side, we see that there's something going on, and this is cytotoxic edema. There is loss of gray-white matter differentiation, and there is effacement of the sulcuses. We go down and we confirm that these changes are confined within the vascular territory of the posterior cerebral artery. So this is in the occipital lobe. The patient has visual disturbances, so it's logical. We relax, we take a deep breath, relax. Yes, what we're seeing correlates to clinical data, because if it didn't, then we had to think what to do next. But in this case, we see loss of gray-white matter differentiation, cytotoxic edema in the occipital lobe. In the right occipital lobe, on the left, it seems fine, which means that there is probably, or there's definitely an infarction going on. That's probably a thrombus in the posterior cerebral artery. Because if you remember earlier, when I showed you the vascular territories, this is the vascular territory of the posterior cerebral artery. Let's see if we can see it, but it will be really hard. No, it's hard. It's hard to see it on the non-contrast CT. In this case, to be honest, I don't know if they would do a thrombectomy. If someone knows, they can say, of course. The patient also has what we call micro angiopathy, or small vessel disease. You see these hypodense areas in different parts of the brain. So obviously this patient has some vascular problem, maybe even some heart problem, that's giving emboli, and he's having small ischemic changes in the brain. But this one is big. This one, there is an infarction here in the right occipital lobe. Oh yeah, one thing. Sorry, I forgot to mention that. While we're looking at all these details and try to correlate clinically, the first thing that you will be asked by the neurologist or from the emergency room, or this is the first thing you should ask from the radiologist, if you're the one assigning the CT, head CT, is there hemorrhage? Literally, you open, the CT is not ready yet, and you already have a neurologist on your head asking, is there hemorrhage, is there hemorrhage? And the reason for that is, and you'll see later when my colleague shows you what blood looks like in the brain, but if there is hemorrhage, this means that this patient can be treated with intravenous thrombolysis, and this is really the first step in treatment. So the first thing you need to look in the brain if there is hemorrhage. You'll see later how to do that. I'm showing you ischemic changes now, but this is the first thing, and then you look to the areas that are affected, and you look, as I told you earlier, if there is a possible large vessel occlusion, because this means that the patient would be indicated for mechanical thrombectomy, which will greatly increase his outcome. But in this patient, actually, we see the insular ribbon on both sides is fine. basically fine. We see when we scroll a little bit and look around, we see the caudate, head of the caudate nuclei are fine, and the lentiform nucleus, the thalamus on each side. Really, the problem is paramedian next to the central line. In the occipital lobe, there is cytotoxic edema. Cytotoxic edema. There is a loss of gray-white matter differentiation, and there is effacement of the sulcuses, which means probably infarction. As I said, there are other causes, maybe encephalitis, but encephalitis, HSV encephalitis usually is confined to the temporal lobes, or there might be hypoxic injury to the brain, which is basically, if you see that, it's basically brain death. So anyway, this you see rarely on a CT, but the whole brain is edematose. You don't see any sulci. You don't see any gray-white matter differentiation. This means that the patient is brain dead. This is not the case here. It's infarction in the occipital lobe. Yeah, posterior cerebral artery infarction. And let's go to the next one. I have, I think, 2 more cases, and then I'll give the word to my colleague so you talk about blood more. This is a patient with recent onset headaches. Yeah, I'll show you one. So can anyone say here, think about edema and think about what I told you in the beginning? Can anyone say, just generally, don't worry about specifics, what you think might be wrong here? This is a patient with headaches. You don't need to put a diagnosis, just on the image. When you see that,
Vasogenic edema.
Yes, great. It's
Good
really
job.
good job. Really good job. Sorry, I skipped a little bit. Anyway, this is on the non-contrast CT. As you said, great. What we see again is a hypodense region, right? Hypodense, darker, but it's confined in the white matter, the subcortical space, the space below the cortex, which the cortex is the gray matter, the white matter is below the cortex. So subcortically, there is a large area, hypodense area. We call it hypodense. It's darker, but not quite like the cerebrospinal fluid here in the ventricles, right? It's hypodense. So there is edema, but compared to what we saw with the earlier patients, we actually can see pretty well the cortex, right? It's delineated. It's actually the gray-white matter differentiation we say in this case is accentuated. And this means you can even better see the difference between gray and white matter, because in the normal brain here, we don't really see that. We see it, but not that well. It's kind of hard. You need to play a little bit, change windows just to make sure that there is no problem. But here you can see pretty well the difference between gray and white matter. And there is vasogenic, as you said, vasogenic edema. And you can see the frontal horn, just compare it, it's a bit fast. So it produces mass effect, positive mass effect on the frontal horn of the right lateral ventricle. And the subarachnoid, the sulcuses on the subarachnoid spaces are shortened, also meaning that they're fast, meaning that there is edema here. All these signs that we see now just point us to the fact that there is edema, but we see the gray-white matter differentiation. So in also one more thing, it goes through vascular territories, right? This is the territory of the anterior cerebral artery, and this here is the territory of the MCA, middle cerebral artery. And all these changes, they don't care about territories. They just go. There is big edema. It doesn't care about any restrictions. Just made the midline. The midline is not shifted that much yet. Maybe a few millimeters. So it's not, the changes we see are vasogenic. So there is no loss of gray-white matter differentiation, which means vasogenic means that the blood-brain barrier is destroyed. Something is destroying the blood-brain barrier. There is fluid outside of the cells. We see that there is no confinement to vascular territories. So it's weird. If this was a cytotoxic edema, and we see this case, and if this was due to infarction, we would think watershed infarction that doesn't respect borders, but no, this is vasogenic edema. And we even see something here. Now, look at these changes, how small they are, and how big is the edema. This is really typical. Can someone take a guess before I show you? Okay, actually, don't take a guess, but can someone try to think what we should do next? Because this is not enough. We're not sure what's going on with the patient. We're not entirely sure.
CT with contrast.
Yes, great. And more specifically, this is the contrast CT, more specifically a delayed phase, or what we call the parenchymal phase, because we don't look so much at the vessels now. We can see them, they're contrasted, but this is not the main part of the main purpose of the exam, because as we established, we're thinking probably this is not a vascular problem. Probably there's something else going on. And what is going on? As I mentioned to you earlier, there are lesions, there are masses inside, and this is some sort of a tumor, or this is the initial diagnosis we make. And then we think, this is an adult patient, there are 2 lesions, they're probably metastases. If it was 1 lesion, it would again probably be metastasis, but it would also be glioblastoma. This is really the most common. There are many tumors, of course, in the brain, but this is really the most common. The other thing we should consider is maybe there is an abscess going on here, because this is what we call rim or ring enhancement, these lesions. So this is the contrast CT, right? We're looking at what is contrasting and what not. This is how they are on the non-contrast. And then we look at the contrast CT, and they are enhancing on the periphery. This one, well, a bit heterogeneous, but this one on the periphery, we call this ring enhancing lesion. And with the ring enhancing lesion, 90% it's a metastasis or a primal tumor, but also it could be an abscess. It's really important when you see that, check the laboratory data, talk with the referring physician. If there is any suspicion of sepsis in this patient, this could be a metastasis. And it's really important because it's life-threatening, like literally hours away from death when it ruptures. Whereas a metastasis, this will take a long diagnostic and treatment period, excision, and so on. But if this is an abscess, it's absolute emergency. You need to do an MRI. And anyway, this is for another talk to show you what the changes are there. But in this case, the patient has metastasis, and this is vasogenic edema. Notice how big around this. The metastasis are not so big, well, not small as well, but the edema is so big. And this is a sign for you to think maybe there is a mass, there is something going on underneath it. And so it was proven as metastatic renal cell carcinoma. One more case. Okay, I had this patient a few weeks ago, I think. And this is, I want to show you this example because this is something that really frightened me. It was 3 o'clock at night. And I got a call that that I'm going to do a CT scan we're going to do a CT scan of a woman that was pregnant 1 week ago, has just had her baby. And she has this left-sided complaints, so to say, neurological deficit. Now, it's a 30-year-old female. And this is really important. Remember, a young female, about the pathology that I will show you now, because it's not so common, but you really shouldn't miss it. Because again, it makes the difference between complete recovery and really bad post-treatment period that could result in paralysis, speech loss, and so on. So I get the patient. I look at the CT, I start from the bottom, everything seems fine, so on, subtentorial, there is no effacement, the parenchyma looks fine, the basal ganglia look fine. I was really worried here. What were the complaints? Left side, right? So I'm looking at the right side, looks fine. I'm looking everywhere, of course, but the focus here looks fine. There is no loss of gray-white matter differentiation. There is no sign of edema. There is no sign of midline shift. There is no sign of hydrocephalus. The ventricles are normal size. And then I go up, and this point, I noticed something that Dr. Karagechev will explain to you now in more detail, but this is subarachnoid hemorrhage. You'll see now, don't worry about it. You'll see that now. What I want you to focus on more, and it's really discrete, and if someone can guess it here, like they should become a radiologist for sure. But and I noticed it only after I saw the hemorrhage, but basically look at the both sides here. Both sides of the brain, they look pretty similar, right? There is no effacement of the sulcuses. And it's something that I've showed you already. So think about it just for a second. There is no midline shift, but, and it's really discrete, so don't worry if you don't guess it.
Blood is in the central sulcus?
Yeah, that's right. This is subarachnoid hemorrhage. Yes, exactly. You're correct. This is subarachnoid hemorrhage in the central sulcus. But what I want you to notice as well is there is a slight accentuation of the gray-white matter differentiation. Look at it on the left side, white matter, gray matter, and look at it on the right side. The white matter is a bit darker, right? I know it's subtle, but if you look at it carefully, you'll see it. So this means that there is some sort of vasogenic edema. There is some sort of vasogenic edema. It's very discrete, very discrete. And we do CT angio, and this is the point where I show you what a CT angio looks like. And by the way, when you see subarachnoid hemorrhage, you almost always do, and if it's atraumatic, and Dr. Karagechev will show you now, we do a CT angio, and I won't go through all of it because it's pretty long to look at all the vessels, and just show you the main ones. Here we have the middle cerebral arteries on both sides. Here we have the ACAs, the anterior cerebral arteries. And here we have the circle of Willis, the posterior circulation, with the PCAs on both sides, the posterior cerebral arteries. But really, the problem here was not arterial. And I'll show you the last image, and maybe someone can take a guess, like an educated guess, maybe, what the problem is. And I'm telling you, it's not arterial. So this is a big sign. And here you'll see it better. This is sagittal reconstruction. And I did this, and also I did this. It's called maximum intensity projection, where we accentuate the vessels. Basically, we lose a bit of detail, but we look at the vessels better. And try to think of the anatomy. I didn't show you this, but it's pretty basic, actually, the venous anatomy of the brain. It's not that complicated. This is the inferior sagittal sinus, and this is the superior sagittal sinus. And here you can see what we call a feeling defect. A feeling defect. So there is thrombosis of the superior sagittal sinus. Here it is on the axial imaging, because you can miss it, right? It's almost on the last slide. So if you don't look carefully, you can miss it. And it's a really important case, because this means that the patient has the vasogenic edema actually correlates to venous infarction. And this is how it presents, with vasogenic edema compared to arterial infarction, where you have cytotoxic edema, loss of gray-white matter differentiation. Here we have vasogenic edema. It's so crucial to notice this, because it's a few days after complaints, the patient had thrombolysis and recovered completely. But if she didn't, she would develop a really big infarction of the brain. She already has infarction, but venous infarction is reversible really well. It responds really well to thrombolysis. So you need to notice this. Think when you see a young woman with some complaints that correspond to an infarction of the brain, think about possible venous thrombosis. I'm sorry I took a bit more of the time.
I just want to add something. This is really a great take-home message for you all. So what we do, we don't only interpret images, we don't only look at the images, we always look at the clinical history, we always try to fit the pieces of the puzzle together. And this is actually a great example, because if you don't think about this pathology as a possibility, as an explanation for the patient's complaints, there is a great chance you miss it. But when you know this is a young female, there are a lot of risk factors in young females for venous sinus thrombosis. Puerperium is one of them. And when you search dedicated for this, then you find it. Otherwise, the chance that you miss it are pretty big.
But I was really close to missing it. So I'm really happy I didn't, because it's crucial. It's really, really crucial. Look carefully. And yes, it's a woman in hypercoagulable state. This is what you need to think about. So you need to look for thrombosis. And anyway, happily, we found it. It's a rare complication, but it's just mainly I want to show you vasogenic edema. slight, really vasogenic edema, and as we said, to think about clinical correlation. Okay, I won't take any more of your time with hypodense, with everything hypodense in the brain. Hypodense, remember, darker. Now we'll move on to hyperdense. I will give the word to Dr. Karagechev. He will explain everything to you. It's, I would say, even a bit more exciting because you see some more dramatic changes in the brain. I'm leaving you for now, and then in the end, maybe we'll have time to do one more case. So I'm giving the words to my colleague now. Thank you for your attention.
Okay, thank you very much, Dr. Kovatchev. And before we begin with the next session that I'm going to cover, let us all refill our coffees, and yeah, let's be back in 5 minutes.
Dr. Kovatchev, you
Yes.
left.
No, I'm here.
And Dr. Karagechev, thank you very much for this workshop.
Yes, we still have more, right? You heard, right? There's still more.
Yes,
left.
but I just want to tell you that it's going on pretty well, and thank you very much for this.
Oh, you're welcome. You're welcome. In the end, we'll give you our details. So I'm happy that there are more than 20 people here. Whoever is interested in radiology, we like, this is our passion. It's almost like our hobby. We at work, even when we have free time, we just talk about cases. There are so many interesting things to see in radiology, and you can always contact us afterwards. So it's a pleasure for us to do this now, even Saturday morning. I know some of you might have better things to do, but it's a pleasure for us, and I'm happy you enjoyed so far. But the next part is really interesting, so pay attention.
Thanks a lot.
And I just want to say, by the way, that this link that I sent you, it will remain there. You can take your time afterwards when you have free time. Look carefully at all the images. There is description there to every image. I sent you the link with descriptions and also the anatomical annotations, so you can take more time. I know I went a bit fast with that part, but otherwise we have to spend 2 hours on anatomy. And you can write to me afterwards if something is unclear. By the way, at the end of the playlist, if you make an account in Radiopedia, you will receive a small certificate from me, an email that says you completed my playlist, which is pretty cool. You can do it. We can do that later.
So I'm here. So I think we can slowly start with the last session. Let me just share my screen and I will ask you to confirm if you all can see it. Okay, I'm ready. If you're ready, can please somebody confirm if you can see my screen?
Yes, we can see it. Thank you very much.
Okay, thank you very much for the confirmation. Okay, it's already. Okay, so 5 minutes passed, and I think we can start with the last session. So, as Dr. Kovatchev told you, in the last part of this talk today, we will talk about hyperdensities in the brain. And I want to start this session by pointing out that not everything that's hyperdense, so not everything that's bright on HED-CT is a pathology. And most definitely, not every hyperdensity in the brain corresponds to bleed. But in order to do most of the little time that we have today, bleeds, hematomas will be the main focus of my talk. So, as the great J.R. Tolkien once wrote in Lord of the Rings, "No, all that is gold does not glitter," and I couldn't agree more with this statement. I just want to add that in the very same way, not everything, as I said, that's bright on HED-CT is blood, and there are a lot of hyperdensities that we need to know and interpret correctly. So, I said in the beginning that we see a lot of calcifications, a lot of these are benign findings in the head, and really typical occasions are the calcifications in the pineal gland, in the choroid plexus, along the falx and the tentorium cerebri, and in the basal ganglia. I will show you some examples. So, this is a normal CT head scan. There is no pathology here. I just want to point out here, exactly in the middle, this is a calcifications in the pineal gland. You can see it's really round, punctiform. There is no associated soft tissue mass, so we don't worry about it. We see this all the time. So again, on both sides, these are actually calcifications in the choroid plexus, in the trigonum of the lateral ventricles. Again, round, punctiform, symmetrical. We expect to find them there. We see them every day, and we are not worried. This can be a bit tricky, actually. These are calcifications in the basal ganglia, and they tend to occur, as you can see, this is on the medial side of nucleus lentiformis. As you can remember, the session from Dr. Kovatchev in the beginning, the anatomy session, this is where the globus pallidus live. And again, they're commonly symmetrical. We expect to find them there. Maybe that's the most important thing. And this is no bleed, this is no blood, this is our calcifications. I will show you an example later that will make this a bit clearer. Calcifications along the falx. And again, this is another example. This is actually no calcification. You can see a hyperdensity in the basal cistern. It's really, really dense, and you have these like streaks around it. These are artifacts. This is actually metal. It is denser than bone. And in this example, this is a patient who had a ruptured aneurysm in the circle of Willis, and this is the coil that they've put in. So this is again no blood, this is metal. So you may think that this looks too easy, and does it play a role for the interpretation? And actually it does. I want to show you an example. This is an article, a pretty old article actually. As you can see, this is from like more than 20 years ago in American Journal of Neuroradiology, and it has this really cool title. And the purpose of this study was actually to see how good or how bad are radiology residents doing when they have to interpret head CTs in the emergency setting. I'm not showing you this article to show you how good or how bad they were. I just want to show you this. Let us hide what we don't and what we're not interested in, and look at this. Only 2 cases in this study had a potentially serious effect. In one case, an atypical pattern of basal ganglia calcification was misinterpreted as possible hemorrhage. As a result, the patient did not receive thrombolysis for an early stroke, and despite the clinical results being uncertain, in this case, there was actually harm to the patient and bad outcome because of misrecognition of findings. So, intracranial hemorrhage, this will be the first part of my talk. And in not only in neuroradiology, not only considering hemorrhages, but in radiology, but in all radiology, in order to be able to answer complicated questions like what is this, or the most complicated question, maybe why is it there, the very first question that you need to be able to answer is where is it? This is the basis of all differential diagnosis. So regarding hemorrhages, we really have 2 options: interaxial inside the brain parenchyma. As you can see, I've tried to put it in this diagram. So this is a process, a lesion. In this case, we're talking about hematomas that is inside the brain tissue. The other one is extraaxial. So these are processes that happen outside of the brain parenchyma. And there are also intraventricular lesions inside of the ventricles. They're actually extraaxial because they don't occur in the brain parenchyma, but for better understanding of the topic, I've decided to put them down as a different subject. So, here we have 3 pictures. These are 3 different patients, 3 different scenarios, and I'm sure that you recognize that every photo has a hyperdensity inside the brain tissue. Maybe they look the same for you. Maybe you recognize some of the things that me and my colleague have already showed you. But if you don't worry. This will be a lot clearer in a few minutes. So we will begin with interaxial hemorrhages. So these are hematomas inside the brain tissue. And here is an image of a CT scan of a patient. Nobody gets a prize for spotting the hematoma. And what we'll do now is we will try to follow a basic approach when we see this. So the very first thing, as I said, location. Where is it? This is a lot important later when you get to answer why is it there. The size is important. The shape, is it irregular? Is it regular? I will show you examples later why this matters. The density, is it homogeneous or heterogeneous? The surrounding edema, exactly what Dr. Kovatchev showed you earlier. Is there any edema? What kind of edema? And is there any intraventricular extension or hydrocephalus? Because this can lead to increased intracranial pressure, herniation, and this could be really dangerous for the patient. So I'll show you a case. This is a case that we saw in our hospital, and CT head was performed in the emergency setting. Like Dr. Kovatchev told you earlier, in a lot of these cases, we actually don't get a lot of clinical information. In this case, an ambulance brought the patient who was found by his relatives unconscious in his home. So we will start from the bottom slices. And I know that you're already distracted. You're already noticing these hypodensities in the frontal lobes. That's a really dark. And for now, you can really forget about them in this case. These are all ischemic changes. And now, when we go down, we already noticed that there is something wrong with the CT scan. I'll just scroll really slowly through the whole scan, from top to bottom, so you can have a look at it with me. I think that was the last slide, and then we'll go up again. So here, what you have is a hyperdense lesion, and where is it? You already know that it is in the right basal ganglia. It's round but slightly irregular, and there is just a little bit of edema around it. So this one of you who look extra carefully maybe have already noticed that there is also hyperdensity inside the ventricles. So this is the third ventricle, the lateral ventricles, and when we go down, there is also blood in the fourth ventricle. If you go a bit up, do you remember this from the anatomy talk? Look at the temporal horns of the lateral ventricles. They actually started to enlarge. So this patient is developing hydrocephalus because of interventricular extension of this hemorrhage. So again, interparenchymal hemorrhage with interventricular extension. This patient actually had a follow-up CT a couple of days later, so we can assess what happens with the hydrocephalus. Is it so we can assess for any progression. And this, I think, is a really nice example. I'll just zoom in a bit. These are the horns of the lateral ventricles, the occipital horn. This is when the patient is lying on the table. This is the most dependent part of the ventricular system, and you see these really nice hematocrit levels. This is a great check area when you look for intraventricular blood. And as you can see, the hydrocephalus hasn't progressed. There is actually less blood in the intraventricular system, which is, of course, better for the patient's prognosis. So again, our three pictures, maybe you recognize one of them already, and I want you, just so you can take something as a home message, I will teach you how to recognize between these three, and we're going to play something that I would like to call a game of windows.
So just to add, probably the interparenchymal hemorrhage ruptured into the ventricles, right? Because first,
yeah, exactly.
And then it ruptured. On this slice, you can see it really well on the left.
Yeah, exactly. That's
where it probably ruptured, right?
Exactly. Yeah, this is important. So the interparenchymal hemorrhage, when they occur in close contact to the ventricular system, it actually ruptures inside of the ventricles, and inside of the ventricular system, it can cause obstruction. So let's begin. Maybe some of you recognize this. We see hyperdensities, very symmetrical in the basal ganglia, in the lentiform nuclei on the both sides. And what is this? What do you think it is? Is it blood or is it something else? I can see the chat actually. I don't know if someone is writing.
I'll follow it. I'll tell you if someone tries to take this.
Calcification, maybe?
Yeah, actually, you're right. And just so you can take something as a home message, I'll show you a couple of ways that you can be sure. What you see here is the very same image, but this is a bone window. We talk about windowing in the beginning. This is a very wide window. You see the great white matter difference cannot be appreciated on this image, but we see that these structures, or actually the biggest part of them, are really dense. They are as dense as the cortical bone. The other thing that we can do is just to put the so-called region of interest measurement. You can see that on the top of the head, and if you measure it, this has a Hounsfield unit of almost 200. And if you remember one of the very first slices, I showed you that blood acute blood is like 40 to 90. Blood can be as dense as this. So this is calcification. When you look at this example, I think you're recognizing this is something like the case that Dr. Kovatchev showed you. There is a hyperdense lesion inside of the brain parenchyma, but there is too much edema around it. And if you look at it, it kind of looks vasogenic, doesn't it? So the bone window, we are kind of able to notice it, but not entirely. So it's definitely not as dense as the cortical bone. And if we put the measurement around it, that measure the house view units, it's around 40. So this is blood. But what is the difference between these two cases? The first that I showed you in the beginning and the last one. So in order to answer these questions, we will go through this image and try to analyze it. So this is a head CT without intravenous contrast, a non-enhanced CT. There is a hyperdense lesion in the brain parenchyma. It is round, maybe too round if you look at it. It's like almost drawn with a pencil. It's slightly inhomogeneous, and there is a lot of edema, a lot of vasogenic edema. So we think that this is not a quick process. This is a thing that was there for a long time to cause this. And history is key in this case. This is a patient with non-malignant melanoma. This is actually a metastasis for malignant melanoma. And even on a non-contrast CT, this can be hyperdense. It is maybe the best example, at least the best example that I know for hyperdense metastasis in the brain lesion. This can, in the brain parenchyma, this can be due either to hemorrhage, so the metastasis had bled in itself, or it can just be due to the high melanin contact of the lesion. So after these short minutes,
what you said here is really important about how there is more. I think we really should remember this. When you see more edema than the lesion, then you have to think underlying cause, maybe like a secondary lesion. Because exactly if it's blood, usually it's acute when we see hyperdense, because blood changes its density throughout time, and in the sort of acute phase, or at least as we catch it after 30 minutes or something, it's hyperdense. But then there is not enough time for edema to develop. So usually to be just small around the lesion, there is small area of edema, whereas here you can see how big it is. And in the case that I showed you earlier with the renal cell metastasis, because it takes a lot of time, it has been there for a long time until it causes symptoms. It has been there, and edema has developed, and so on. So really think about that. When you see big edema, think something that has taken a long time to develop. So probably underlying neoplastic process.
Exactly, and as Dr. Kovatchev showed you in the last, in his last session, so in this case, give contrast. So look for something else. And that was our game of windows. I'm sure that you can already handle this free. So I'll show you another case. And when this is, again, not a lot of clinical information, I'll show just case just to prove the point that we made in the last few slides. So this was a patient with known scalp malignant melanoma, surgically removed a couple of years ago, and the patient had an unprovoked seizure. So we start from the top of the head, and I'm sure that all of you are already noticing a couple of abnormalities. These are here, this really round, again like pencil draw, hyperdense lesions with edema around them. And when we go down, there is actually a better, opposite the other side down, there is actually a better example right here in the inferior frontal lobe. When you see these lesions again, there is no loss of great white matter differentiation. It actually looks accentuated. This is again vasogenic edema. We go further down, a lot of more of these lesions. Of course, in this case, we knew that the patient had a history of malignant melanoma, we expect this to be metastasis, but this is only the tip of the iceberg that we see. So what we do next is we give contrast, and in the parenchymal phase, so we inject the contrast, wait for like 3 to 5 minutes so the contrast can fill the brain parenchyma through the broken blood-brain barriers, and this is what we see. So there were so many other metastatic lesions hiding inside of the brain, and also infratemporal in the cerebellum. Again, a couple of lesions. So just an example, so we can really, so that you can really take this home with you. There is important difference. So you have to know when to do something more, when to give contrast, and how to differentiate between two. So the last thing I'm going to talk about will be extraaxial lesions, extraaxial hemorrhages. And in order to understand their morphology and to be able to differentiate them from one another, we will have to talk about the anatomy of the brain meninges really quick. So there are 3 layers: the dura mater, the arachnoidea mater, and the pia mater. And yeah, this was one of my first attempts with Adobe Illustrator, but I think that I can explain it better than I have drawn it. So here is the calvaria. So this is the skull. And inside of the skull, so overlying the inner table of the calvaria, is the dura mater. And the dura mater is firmly attached to the skull, and it's actually composed by 2 layers. They're actually called like outer and inner layer, but if you want to sound more academic, you can call them endosteal and visceral layer. And the most important thing for now is to remember that the endosteal or superiosteal layer, the parietal layer of the dura, is continuous with the brain sutures and respectively continuous with the periosteum on the other side of the skull. So we go from the other side to the brain parenchyma. And the next is the arachnoidea mater. Between arachnoidea and dura, there is actually no real space. It's a potential space. There are connections, but they're really loose, and it is a potential space for subdural hemorrhage. Beneath or deep to the arachnoidea mater is the only real extraaxial space. This is the cerebrospinal fluid, the space that contains the cerebrospinal fluid, the subarachnoid place. And what I want you to remember is that it's continuous with the brain sulci. So it goes deep into the gyri, and the sulci of the brain are actually part of the subarachnoid space. The last layer is the pia mater, and the pia mater is actually inseparable from the brain cortex. Everything deep to the pia mater will be interaxial or interparenchymal. Everything outside of the pia mater will be extraaxial. And the first example, I will start by taking you to all 3 types of hematomas that you will encounter from outside to the inside. And the first one is the epidural hematoma. And the epidural hematoma is hemorrhage that occur between the inner table of the skull and the dura mater. And this is, like I said, not a real space. It's a potential space. And if you have listened to what I've explained, this is really important because the endosteal layer is continuous with the skull sutures. The epidural hematoma will be contained by the suture, so they won't cross unless, of course, there's a fracture through the suture. So extradural hematoma and epidural hematoma are actually the same. Here you can see a nice example, hyperdense lesion along the brain convexity and this is an epidural hematoma. There are a couple of important characteristics of epidural hematoma. As I said, it occurs between the inner table of the skull and the dura. This is basically a superiosteal hematoma. It has a typical shape. It's biconvex or lentiform. It is often results from a skull fracture, as in this case. So here you can see this linear fracture. Now I'm sure you can see it. And a couple of important things I want you to remember about epidural hematomas. So there are a couple of findings that we need to recognize. So these hematomas, they tend to go bigger. They tend to gain volume. And when, like Dr. Kovatchev told you, everything that gains volume inside of the parenchyma gets to apply mass effect on other structures. So this is really crucial for the patient. And there are a couple of findings that we need to recognize. So we measure the thickness. Thickness is the size, so the diameter between the inner table of the skull and the other margin of the lesion. There is a way to measure the volume, but I won't go into details. Just have that in mind. You can check it if you're interested. And midline shift. We are always worried about midline shift, and this is how we measure it. So this is the sagittal line just in the middle, and we use the corpus, the septum pellucidum. In this case, there is dislocation from the midline. You can see it here, like almost 9 millimeters. So midline shift greater than 5 millimeters. These are all findings that when you see them, we need to pick up the phone and we need to call the neurosurgeon, because he definitely wants to know if you operate immediately or not. It's his decisions. There are a lot of other factors. I'm sure that many of you are aware of the Glasgow Coma Scale with the clinical evaluation for the patient, but these are something from radiologist's point of view that we need to recognize and we need to report. And again, I want to show you something else. If you look extra carefully on this side, we talk about assessing symmetry and asymmetry. You can see that this hyperdensity, but outside of the skull, this is actually a hematoma, a scalp hematoma or subgaleal hematoma, if you want to sound fancy. I just want to point out, in the setting, especially in the setting of trauma, look on the soft tissues of the look at the soft tissues of the head, not only the skull, not only the brain. Look at the head. That is why it's called head CT after all. And if you see a scalp hematoma, then this is a good indicator that you want to look deeper to see what's beyond. And there is a very big chance that there is a sculpture, a fracture or a septohematoma. We always see it. And because I want you to remember, if you forget anything else, just remember how an epidural hematoma looks like. It kind of looks like a lemon. At least in a lot of books, they compare it with a lemon. And this is a very easy way to remember it. Epidural, epi, is actually an acronym for pie. And a lot of pies, you know, the lemon pie. I think you remember it this way. So the next space is the subdural space. As I said, this is also a potential space. This is between the visceral layer of the dura mater and the arachnoidea mater. And I'll show you an example. As you can see, this is a very typical example of subdural hematoma. I will show you the main characteristics of such hematoma. So it goes along the hemispheric convexity in the potential space between the dura and the arachnoid. It has this very typical crescentic shape. Let's remember the epidural hematoma, it had a lentiform shape. This one has crescentic shape. It's most frequently due to trauma, but not always, but I won't go into details. It's usually venous in origin, and it's not limited by the sutures. It's not limited by the sutures. And this can be tricky. I'll show you an example why. So remember, in the beginning, we talked about windows and the problem with the normal brain window. So this is normal brain window. And when you look at this image, it kind of looks absolutely normal, doesn't it? So the brain parenchyma that we see looks okay. There are no hyperdense lesions inside of the brain parenchyma. There is no midline shift. excuse me, no hydrocephalus. But again, clinical history is key. In this case, we know that the patient had suffered a motor vehicle incident, so we need to look extra carefully for traumatic brain injury. And of course, because we are always looking systematically, we switch on to the subdural window, and as you can see here, along the convexity of the brain, there is a really subtle subdural hematoma. You can recognize it crescentic in shape, just along the inner table of the skull. So if we didn't switch to subdural window, we would actually have missed this.
And also you could focus even on the non-contrast CT on the sulcuses and see maybe if there is some slight displacement. You should see them clearly, how there is cerebrospinal fluid, and you can follow it to the skull, and there is some slight displacement there. There shouldn't be. There's always worrying. Sometimes this is a really hard case, but sometimes it's more evident. Although you don't see it as hyperdense, you see some displacement, and then this can be a sign as well. Even if you don't actually see the blood, it's just like indirect sign.
Yes, exactly. So a good point. So as we have said many times during this talk, as always assess for symmetry and asymmetry, and this can be really subtle sometimes. But the main point, don't forget the other windows. And because I don't want you to forget how a subdural hematoma looks like, again, they often compare it with lemons and bananas. Radiologists are crazy about science. They're crazy about comparing their findings with other things. And I think this is really easy. Subdural, sub B for banana. So the last thing that I'll show you today is subarachnoid hemorrhage. As you remember, this is beneath the arachnoidea mater in the CSF containing space, the subarachnoid space that tends to be continuous with the brain sulci. I think this is a very typical example. When you look at this image, you see there is hyperdensity inside the brain sulci. We call this a sulcal pattern, and you can see this is the normal brain sulci filled with hypodense cerebrospinal fluid, and I think you can appreciate the difference really well. So the CFS spaces, they're continuous with the basal systems. Dr. Kovatchev explained the anatomy in the beginning, but this image is really important. I really want to remember it. If you try to picture how the normal anatomy looks like, these are the basal systems. This is where the sulcus of Willis lives. And when you see this, the subarachnoid hemorrhage are these hyperdense. We see them as hyperdense areas that conform to the morphology of cerebral sulci and cisterns. And when you talk about etiology, it is really a long list of possible differentials. And don't read this. I just want you to remember this. In almost all of the cases, the etiology of subarachnoid hemorrhage is ruptured aneurysm. And a take-home message, if you forget everyone else, just remember, if you notice massive subarachnoid hemorrhage in the major system, you have to rule out ruptured aneurysm. And the way to do it is with CT angiogram. I will show you the case. So again, emergency setting, late at night, we don't have sufficient information. The only thing we know is that the patient presented with a headache, and this headache, the patient himself described as the worst headache of his life. This is really typical for these cases. So we start from the bottom, from top to bottom, and the very first slices they see actually completely okay. So nice great white matter differentiation. We see the sulci filled with CFS, and we tend to go down to the bottom. And here I'm sure that you already start noticing the abnormalities, this sulci pattern of hyperdensities, but it's not really dramatic, isn't it? We continue down, and we see this. So hyperdensities that are filling the basal cisterns, exactly where the circle of Willis lives. Maybe a small developing hydrocephalus. It's really normal in supraorphanite hemorrhage to get hydrocephalus. It's an important thing to be reviewed. And also infratentorial in the CFA spaces. So what we do now is we continue the scan, we do a CTA. So we inject contrast media and we follow the bolus rapidly in order to obtain vascular imaging. And I won't go into details, but again, this is how it looks like. And exactly where we saw the hemorrhage, in the circle, around the circle of Willis, in the basal cisterns, there is this large aneurysm of the right MCA. So this is how CT angle looks like. Oops, sorry about that. Just let me go back to what pertains. This is actually the last case of my presentation. There are only a few minutes left, and I don't know if you recognize this quote. This is from the great Twin Peaks. I actually watched it years ago before I started my radiology residency. And this is a quote that even the most hardcore fans of the series never understood what it actually meant. The O's are not what they seem. And when I started my radiology residency, I found myself very often thinking about this quote when looking at images, because as you can see in the next case that Dr. Kovatchev has prepared for you, the things that we see are very often not what we think at first. Dr. Kovatchev?
Yes, thank you very much. It was a great presentation of hyperdensities. I know that the time is over. I'll just show you one case that combines what both of us try to teach today. I understand it's over 2 hours. If you want to go, don't worry about it. But if you want to stay for one more case, you can continue in the playlist that I sent you in the beginning. It's still in the chat. So the last case of the playlist, I'll share my screen again. I'll share my screen in a second. Or you can just watch my screen, but it's all saved in the playlist to review later if you're interested. This is, again, actually, both of us were at work, then I remember, and I was just coming in for night shift, and I received the CT of a patient. So this is later on, sorry. In the first CT is before that. This is a patient that's 8 years old and has atrial fibrillation. It's important. And the complaints are on the left side. First of all, she can't speak well, aphasia, and left hemiparesis. So think about this. We expect something on the right, but as always, look at everything. Let's look at the first CT. This is upon admission of the patient. One thing I didn't mention, because this is an 80-year-old patient, you see this often, and it won't strike you as evident if you haven't seen enough head CTs, but you see how the sulci are deeper, a bit. You can see them really well, and they're even a bit dilated, I would say, just slightly, not pathologically. And this is normal in the aging brain, because even if old people don't necessarily develop dementia, cortical atrophy, and so on, the brain still atrophies a little bit. So this is normal in an older brain, to see how these dark suprarachnoid spaces are a bit more evident. And also sometimes you can see this in the ventricles. They can be slightly dilated, but it will be symmetrical in the middle, on the both sides symmetrical. This is just part of aging. It's normal. But anyway, to get to the pathology part, let's look carefully. And by the way, you can unmute your microphones, whoever's still watching, if you want to give a suggestion. If you're looking at yourself, think about the things we talked about today, especially the take-home messages. I understand that you can't remember everything. It's absolutely normal. It took us a lot of time. But let's think about this patient. This is with left aphasia and left hemiparesis. First of all, if we start from the top, we see the good gray-white matter differentiation. We see these dark spots, let's say. These are areas, small areas of hypodensity. Again, micro angiopathy. Normal again with, well, not normal, but it's common with the aging brain. Even we see on the left side here, there is a very well circumscribed hypodensity. It's either a dilated perivesical space, which is again a normal finding, or it can be a small lacunar infarction. This is a subtype of the cerebral infarction, but it's old because you see how well it's circumscribed. It's hypodensity. It's almost the same density as the cerebrospinal fluid. But actually, what we see, it's important, is what I showed you earlier. I said about insular ribbon sign, right? Loss of the insular ribbon. However, here it's not so evident. On both sides, we can pretty well follow the insular cortex. What we can see really well, however, is the gray-white matter differentiation in the basal ganglia. On the right side, this is the right side, this is the left side. We are thinking they might be a pathology on the right side clinically. And really, on the CT, we see how the lentiform nucleus has its borders a bit smudged. They're not very well differentiated. Whereas when compared on the left side, it's really good. I mean, for an 80-year-old woman, it's really it looks pretty good. So this is first point of concern. And then we see this. I'm sure you, even if you don't want to speak or write, I'm sure you notice it now because I really focused on it. Think about the arteries, the carotid artery coming inside, going as the middle cerebral artery on the left side. You can follow it with a density that's similar to the brain because we don't have contrast, surrounded by cerebrospinal fluid here. Inside the basal cisterns, as you mentioned earlier, the circle of Willis, and it goes to as a middle cerebral artery to the left. But on the right side, we see the internal carotid artery, and here it's already the middle cerebral artery in the M1 segment of the middle cerebral artery. So this is the first segment, and we see how it's hyperdense. It's white, hyperdense, and this is a hyperdense MCA. As I said earlier, this is really strong indication to do, strong indication for a thrombus, and immediately we need to do CTA. Did I miss something? Yeah, aspects this is a grading system, maybe for a second workshop. And as I said, no hemorrhage. You already know how to notice hemorrhage. There is no hemorrhage intracranial. It's actually the first thing. There is no hemorrhage. So the patient is indicated for intravenous thrombolysis, but also, as we see on the angio, which is the next CT, should be, yes. On the angiogram, or CT angio, however you want to call it, this is with contrast, arterial phase, as was explained. We follow the arteries closely. Let's look at the healthy side first, how it normally looks like. The carotid artery, this is the posterior communicating artery from the posterior circulation. And then it turns into the MCA, which you can clearly follow really far away without any filling defects. So they're homogeneously contrasted. There are no filling defects. But on the right side, from the intercarotid artery, then goes to the MCA, middle cerebral artery, and then here there is a straight cutoff. There is a filling defect, and we can't follow it anymore. This is how a classical image on an angiogram of a thrombus. And just back to the native, to the non-contrast CT. This corresponds, right? It corresponds to what we see on the non-contrast CT, but the cortex is preserved here. The white matter differentiation. There is no evident edema on this side. However, because there is collateral circulation from ACA and PCA, but the basal ganglia, there is a problem. There is something going on. There is cytotoxic, slight cytotoxic edema without big mass effect, but it's there definitely. And what happened is, for this woman, they decided, because there are many factors that go into that, but they did intravenous thrombolysis, and they also did mechanical thrombectomy. So they went inside, whoever doesn't know what this is, with a stent and to the brain, or with the catheter, sorry, to the brain, and they actually retrieved, it's called clot retrieval. They got this clot mechanically and just took it out. It was pretty big. They took it out because she was in the first 6 hours. She had good cauterization. She had good access. We used the angiogram also to evaluate carotid arteries, the aortic arch, to make a map for the interventional radiologist so that they know where to go to and how to get to there. So they retrieved the clot, and immediately they retrieved right before I went into the night shift, and immediately sent her for another CT right after the procedure, like in the first minute. And this is the CT that I will show you now. And think so. This is the same patient a few hours earlier, right after the procedure, mechanical thrombectomy, and she also had intravenous thrombolysis. So think about what Dr. Karagechev was talking about until now, and try to. Can anyone? Well, you don't have to say what it is, but at least what do you see? Is it hyperdense? Is it hypodense? Where is it? Like these initial things. Can anyone take a guess?
Hemorrhage in the basal ganglia.
Great. This is exactly what I thought. Like I opened the CT. So it's just a second, sorry. There is something hyperdense, right? So that's why you think hemorrhage. And it's confined within the basal ganglia, which means interaxial interparenchymal hemorrhage. And also, this is a slight note, we can see this is a non-contrast CT, but the patient just had thrombectomy, right? And during this digital subtracted angiography, which is the conventional angiography they do in interventional radiology, they give contrast. And this is there is residual contrast in the vessels. That's why you can see them so well. You notice it's a non-contrast CT, but the vessels are really well seen. This contrast from the previous study that was done during the intervention, and in it you can follow now this middle cerebral artery that was thrombosed earlier. You can follow it distally, so it was successful in this, and at least in this aspect. But as you said, exactly, you're completely correct. This correct conclusion to make. This is a hemorrhage. This looks like a hemorrhage, exactly what you were shown until now. And this is what I saw, and I asked Dr. Karagechev was next to me, and I said, wow, there is a huge interparenchymal hematoma. What do I do now? I called one of our colleagues who's an interventional radiologist, but exactly because in these cases, you need to start thinking a little bit, and I had no experience with that. It's fine. It's fine that you don't know something, but I had no experience with that. We discussed it, and Dr. Karagechev told me one article and also one case of earlier, similar, but it was instead of here, these hyperdensities, they were in the cortex. And this, what actually is, it could be a hemorrhage. That's not excluded. Of course, it could be a hemorrhage, but it could also be contrast developing or yes, there a big contrast remnant, if you can say like this, because as I said earlier, think of the anatomy. The basal ganglia are supplied by terminal arteries that have no collateral. So when we inject contrast in these arteries, and there is swelling here, the contrast develops and stays inside here for a small period of time before it can drain. And we did this study right after the procedure. So actually, differential diagnosis here is, of course, could be hemorrhage, which is one of the complications of such a procedure as mechanical thrombectomy, but it also could be contrast staining. That's what it's called. That's how we described it. It's here. So hemorrhage or contrast staining. And luckily, because if it was hemorrhage, then this would mean hemorrhagic transformation of the infarction, right? And this is not really good prognosis. It's a complication of ischemic stroke. So what we do is we do a follow-up study 24 hours later. Now, again, you're doing really well, by the way. If someone wants to say what they think is happening here, just one second, because my battery is almost dead, but it should be enough. What they're seeing here, this is the same patient 24 hours later. And some of these things I haven't explained, so it's totally fine. Think about maybe mass effect, think about hypodense areas, think about, yes, edema. And think about, do you see blood or do you see a lot of blood? This is the same patient 24 hours later. This is the area that's of interest. So at least we should probably have an idea in your mind. Is it hypodense? Is it hyperdense? So that's why we divided the presentation like this, because this often is the starting point. What we had here, big hyperdense areas, are now pretty much hypodense, except for these small points, but they're not really bright. This one here, it's like punctuate hyperattenuations. But overall, the ischemia is developing. I mean, it's inevitable. The patient was treated, but still there will be some deficit. And there is some mass effect you can see on the frontal horn, initial positive mass effect, because if you scan this patient in 6 months or 1 year or 2 years, we will see that this area here that is infarcted, this area here, will have lowered its density and lowered its mass effect. It will basically shrink because there is cerebral malacea, so the brain is dead. There is nothing left there, and it will start extending negative mass effect on the frontal horn, and instead of pushing it in like this, to actually start pulling it. So this is how you know when the infarction develops in time, but still this is pretty acute. It's in the first 24 hours. And what we see is that there is no hemorrhagic transformation. The contrast has already washed out. There is no contrast. There are small hyperattenuating areas, which we call, and histologically are most likely petechial hemorrhage. So small hemorrhages inside the parenchyma, but there is no major hemorrhagic transformation of the brain parenchyma. So this is a good sign. The procedure was successful. There are no major complications. The best that could be done for the patient was done. And yes, let me see if I missed something. Yes, scattered hyperattenuations. And this is basically it. I want to leave you also with some messages. Otherwise, the workshop is over. I'll also give the word to my colleague if he wants to add something. But I just want to say that I'm really glad that you have interest. That you have an interest in this field. It's really, really interesting. If you want to become a radiologist, or you already are, some of you, or if you're in another specialty, you need to understand these things when you assign exams. Our boss often says, it's one of the things I remember, we need to be aware of what we can see as much as what we can. So we need to know our limitations. As you can see, it's not perfect science, but it's really, really interesting. And I hope that when you're in emergency situations, you remain calm and you try to make logical connections. You have sources of information that are reliable to you, and you don't panic if you don't know something. Just remain calm. Trust me, you'll do fine. If you become a radiologist or whatever you do in an emergency setting, it will be fine. And this was from my part. I think, was there last
Thank
slide?
you very much, Dr. Kovatchev. This is actually a great case that my colleague presented to you. It's something that we don't see every day, that has confused us, and it gets to confuse people in common, because mechanical thrombectomy, we won't go into details, but it's actually something that's pretty new from this century, and these kind of cases, they tend to be recognized in the last couple of years more and more, because many more mechanical procedures are performed also here in Bulgaria. And up to me, I will have it's up to me to close this presentation, and let me just share my screen. And just a second, please.
Yeah, you'll see our contact info as well if you want to contact us.
Again, this was really one of the best examples for the author, not what they seem when you think about something and it turns to be out something completely else. So we are really thankful so many people stayed until the end. I know it took actually a lot longer than we expected, but it's harder when it's online. We are really looking forward to the time when these sessions and these workshops will be held in person, not in front of our screens, because the communication, this type of the communication in person is really priceless. In the end, we want to acknowledge the support of the head of the radiology department in the GBDM City Clinic University Hospital Tukuda, Professor Galina Kireva, and the whole staff of the radiology department for their support during our everyday tasks. And the preparation for this workshop was no exception. Again, thank you all for your attention. We're really glad that so many people joined, that so many people stayed until the end, that you answered questions, that you tried, that you took part. It was really great. Thank you all. And these are our contact data, our email addresses. If you have any feedback, any suggestions, no matter if positive or negative, we will really appreciate it. Really, thank you all for today. Thank you.
Thank you. Have a nice weekend, and I hope to see you soon.
Wish you all the best.
Bye-bye.
Thank you so
Dr.
much.
Kovatchev and Dr. Karagechev, thank you very much for this workshop and for making it truly engaging. Dear participants, if you haven't registered for ICMS yet, please do so. We are expecting to see you there.
Thank you for the workshop, guys.
Thank you very much.